So we are going to get started in a topic that we don't discuss very often. We're going to be talking about dealing with end-of-life issues in the field. So quick show of hands, who here is going to die at some point? Oh, I got one head shake. All right, man. Good for you. We're all going to die. It's unfortunate to think about, but it's true. And it's something we honestly don't talk about. I've been in and around pre-hospital care for 25 years now, and I've never seen a lecture in pre-hospital care for end-of-life issues. So I think it's actually important we talk about this. A little bit of my background. I know a lot of you here, but I'm an assistant professor of emergency medicine here at UF Jacksonville. Been here for about 15 years now. Come across many of you folks. But now, as I kind of progress through my career, my next step is probably going to be palliative and hospice. I'm taking specialized fellowship training in that right now because I've seen a lot of the gaps in our care and where we can improve that in the emergency department. We can also improve it in the field. You all are the first point of contact for these patients. So treatment starts with you. Collection of information starts with you as well. So I think it's really important that we actually talk about end-of-life care. And I'm sure you all have come across some cases that have been tough to deal with. And we're going to kind of just discuss a couple different facets of it. I'll go through that in a second. I did want to bring up James Tucker, Lieutenant Tucker from Fernandina Beach Fire Department, a good friend of mine. 361 days ago, he passed away suddenly at home, out of hospital cardiac arrest with his family at home. So just a reminder that we all die. This is a very amazing person, a fit firefighter. Led a great life, and he died suddenly. Same age as I am right now, so that kind of makes you take a step back and think about things. But just it's an unfortunate reminder that we all have our time in life, and I just want to dedicate this lecture to him as his anniversary of his death approaches. So again, we all deal with some end-of-life care issues in the field. We all, I don't want to say all, but I would bet most of us want to die at home, comfortable with our families. When you look at surveys of Americans, about 70 to 80% of people want to die at home, surrounded by family. Unfortunately, we have a medical system that's set up kind of to block that, not for bad reasons, but because we want to do as much as we can. Our medical system is built on throwing everything at people, especially at the end of life, usually when it doesn't have much benefit to anyone. So in the system that we work in, it's kind of a fine line of keeping these folks where they may want to be when the end of their life comes, and maybe putting them in ICU where they may not want to be. And a lot of this can actually come down to your care and your treatment and the information that you gather. I think more and more as a lot of our medical systems change, especially new medics and new EMTs are often just kind of seen as a ride to the hospital. And they don't really appreciate the role that they play in gathering this information and starting a patient down a good pathway to the care that they need. So why I'm going to talk to you about this seems like a hospital problem. But you obviously have enough on your hands in the rig, in the ambulance, and the helicopter. You have enough to do, often with a very short ride time. But again, you are the first point of contact. And a lot of this comes down to communication of the patient's wishes and values that may be known by the patient and may be known by the family. You may not be aware of this, but families sometimes just don't show up to the emergency department, or sometimes it takes hours before they show up. And we might have a patient who actually doesn't want any of these life-saving efforts done, and now they're intubated, going to the ICU on mechanical ventilation on a bunch of drips with a central line in them. And there's no way for us to know that. So on top of everything else that you guys have to do, if you're able to take that little extra time when you kind of identify that patient, saying, this looks like an older patient with serious illness, and maybe talk to family, hey, have they ever expressed their wishes? Do they have any paperwork? Have you ever talked about this? Is this something do they want to be intubated? And we're going to go through all these questions, but things we should talk about with the family patients. And so this is kind of the continuum of care when it comes to serious illness. This isn't just for patients who are end of life. This is anyone with serious illness. You come in septic with a bad pneumonia. You come in with end-stage renal disease. You come in with a TBI. You are put on this pathway of serious illness. And when we start on the left, that's all of our prevention, everything we do before something bad happens. But as we experience serious illness, you can see as we progress across, our curative care decreases. So what we can actually do for a patient as serious illness goes on decreases. There's only so much that we can do. We may try to do a lot, but anything that actually has benefit, there's very little we can do. What does increase and what should increase is palliative care. So palliative care is kind of an umbrella term for individuals with serious illness, and it takes their values and goals of care in hand, and it tries to tailor things like symptom management. like pain management, nausea management. Also tries to get a good plan together. If this person decompensates, gets worse, what do they actually want to have done? Does anybody here want to die on a ventilator in the ICU? Cool. I'm sure a couple of people are like, yeah, do everything for me. But that's not what most of us actually want. So once you start involving teams like palliative care and having that mindset, we're able to maybe avoid that outcome that majority of Americans don't want. As we get into the last, especially 6 months of life, that's where hospice care comes in. I'll talk specifically about hospice care in a little bit because I think there's a lot of misunderstanding as to what hospice actually is. And so you're often the best source of this information. You see the patient's home. You talk to the family. I know a lot of you go to the same patient 10 times a month. Yep, we know Mrs. Jones very well. So you see their disease progression. All the time you guys come to us and say, I know Miss Jones really well, and she ain't like this usually. Usually she's much better than this. And that kind of information is information that we don't usually have in the emergency department. So it's super helpful. So again, you're the first link in a long chain of healthcare. And so for these reasons, you need to be aware of a couple things. This is what we're going to talk about today. We're going to talk about what advanced directives are and what they might mean for your care, what hospice is and how do we go about treating these patients. We're going to talk real quick about obtaining rapid goals of care. So when someone's really crumping in front of you and you might think this is a patient that may not want this intubation, how do we have those wishes expressed? And also termination of resuscitation. Something that some agencies may do in the field. Most agencies have some sort of protocol for. And we're going to go case by case, just some quick cases, to discuss all these things. And obviously, please stop me if you have any questions. So our first case, we have a 50-year-old male, end-stage lung cancer, no longer receiving chemo. So he's in the phase of care where they've realized the chemo is not going to do any benefit. So he's just in the end stages of care. He's currently considering home hospice, but has not yet enrolled. He has known large pleural effusion, so lots of fluid in his lungs. EMS is called for severe shortness of breath, and patient has signed a DNR. So who's picked up a patient with an active DNR? I'm sure many of you folks have. This is what our Florida DNR looks like. I want to go through what a DNR is and the different aspects of it so you can maybe have a better little understanding of what this document means. So a Florida DNR, to be legally binding, it can be a copy of it, but it has to be on a bright yellow piece of paper. Whatever shade of yellow is fine, but that is the weird rule that we have in Florida that has to be on a yellow piece of paper. It can be a copy, though. It does not have to be the original. It has to have the patient's information. It has to have a signature of a physician. A DNR is a physician order. So a couple different parts of this DNR. First off is the patient statement. And this says, based upon informed consent, I, the undersigned, hereby direct that CPR be withheld or withdrawn. And if not signed by the patient, it's going to be signed by somebody else. So what this form says is this patient has a legal physician order to withhold CPR. CPR is kind of a nebulous term, but we generally take that to mean no compressions. We generally take that to mean no intubation and no defibrillation as well. There's also another thing I want you to be aware of, and it's called a PULST form. I'll get back to the DNR in a second. But a PULST form, someone might hand you this as well. So this is your DNR. That bright yellow form is a DNR. This is what's called a PULST or a MOLST form. And this is another sort of physician order, but it has a little more expanded criteria. So these are often patients who are enrolled in hospice or patients coming from nursing facilities for long-term care. And this has same types of things. This has attempt resuscitation in CPR or do not attempt resuscitation in CPR. So it has some different categories. It also has some different medical interventions that person may want. So full treatment at the top, meaning do everything. Limited treatment, it'll list off things they don't want. And at the bottom, this is important to you. You might be handed this form and it actually says patient prefers no transfer to hospital for life-sustaining treatments. Transfer if comfort needs cannot be met in current location, and consider hospice or palliative care referral if appropriate. So you might be called to the scene by someone who doesn't realize the patient has this, and another family member comes in and says, here's their PULST form. They now have a legally binding physician order that says do not take this patient to the hospital unless their needs cannot be met at home. So the family may be like, yeah, their pain's so out of control, we want them taken to the hospital. Cool. But you might have a family member saying, no, they do not want to go. And this is a good time to pump the brakes and maybe talk to your chief or your medical direction and say, hey, this person has this form. Should I transport them? Because really they should not be transported to the hospital unless it goes beyond the confines of this form. They then have artificially administered nutrition, so it doesn't have much to do with you. I just want you to be aware this is the other part of a PULST form. If you're in the hospital and you have one of these forms, it says I do or do not want tube feeding, essentially. So these are usually forms that are for people in really, truly end-of-life care. So DNR is not do nothing. A DNR is do not resuscitate. It does not mean do nothing. What it means is do not intubate, do not do CPR, and do not give defibrillations. Beyond that, you can really administer any of the treatments. There are some forms that tease out, yes, I want compressions, but I don't want intubation. It really makes things tough. But really, if you see a DNR form, think I do not do compressions, I do not intubate, and I do not defibrillate this patient. But there are things we can do. We can give fluids. We can give pain medicine. We can give nausea medicine. We can give oxygen. We can use non-invasive positive pressure ventilation, and we can take these patients to the hospital. So there are plenty of other things we can do. I don't want you to think a DNR means do nothing. So as the medic or the EMT shows up on scene, you are presented with a DNR or a pulsed form, but the patient isn't active extremis. You can ask things like, do you want to go to the hospital? I see you have this form that says you might not want advanced treatment. Do you actually want to go to the hospital? Are you okay with oxygen? So a lot of times end of life, one of the most common end of life symptoms is dyspnea or difficulty breathing. So allowing them to have oxygen to help them, giving them medicine like opioids to help with dyspnea as well can be very helpful. And other things like CPAP or BiPAP to help their work of breathing. A lot of these folks are in the end of their life and they know that and they know they're going to die. They suddenly feel that death coming on. They can't breathe. They really freak out. Family calls 911. They're not sure what to do. So at that point, transport and do comfort care. So going back to the DNR form, the next very important category is talking about the person who might be signing the form for this person. So someone may have a DNR where they weren't able to sign it themselves because of mental capacity or some other reason, and so they actually have someone signing for them. It's very important to understand the different categories that are in this form because this is a major legal binding issue here, and we need to make sure we have the right person speaking for the patient. There's 4 categories on this form. There's a surrogate, a proxy, a court-appointed guardian, and durable power of attorney. All of these people legally can sign for this patient if they are these documented positions and make medical decisions for these patients. So as we get older in life and we might think we may not be able to make our decisions as we get sicker and sicker, many people will appoint someone like this legally that can then make their decisions for them. So we can go through each one real quick. A surrogate. So a surrogate is a form that's filled out with a list of names and people can make decisions for them. So you right now today could go make a healthcare surrogate form. You can write it out on a piece of paper. You can print out a form online and say, I want my sister, my brother, my dad, whoever to be my healthcare surrogate if I can't make my own decisions. It doesn't mean today they can make your decisions. It means 10 years from now you have a bad traumatic brain injury and now you can't make decisions and they're turning to that person saying, what do you want us to do for her? They are now legally able to make that decision. And this is something that, again, a form you just sign out and fill out and sign, doesn't involve lawyers or anything else. There's a court-appointed guardian. So that is someone who is an incapacitated individual, especially minors, if their parents are unable to be their surrogate. So for whatever reason, they may not live with the parents anymore, the parents have drug problems or incarcerated, something like that. The parents are deemed ineligible to make decisions for their child or for their other minor. The court will actually appoint someone. So when you see this DNR form, you might see court-appointed guardian checked off that DNR form. A great question to ask is, who is the court-appointed guardian? Do you have that paperwork? Because we got to have that stuff in the hospital. Because if you guys arrive with nothing, then we're just going to have to do everything for this patient. So we really need that kind of stuff known to us. The next is a proxy. So a healthcare proxy is someone who has the decision-making authority. It means nothing was filled out before, but there's nothing saying who this person should be. So now the court has to decide who's going to make the decisions. In the state of Florida, there's a hierarchy. So if you go to the hospital today and you are unconscious and can't make decisions, and we need someone to help us make decisions, this is who's going to make your decision unless you otherwise specified. If you have a guardian, they're going to be the first one. If you have a spouse, they're going to be next. If you have children, then parents. So this is the hierarchy we go down. So if you don't trust your spouse to make these decisions, that's a great time to fill out a surrogate form and have someone else do it. I have plenty of people who would not trust or would not want that decision-making capacity to be with their son or the daughter or their spouse. Not so much a trust issue, but maybe that person just can't handle that kind of decision weighing on their shoulders. So this is why you'd fill out a form saying, I want so-and-so. It could be a friend to be my healthcare surrogate. But if you don't have that, this is what state of Florida is going to go through to determine who's going to make your decisions. And again, to get back to what a legal state of Florida DNR is, and that state of Florida DNR will only work in the state of Florida. It's signed by a patient or their legal representative. It's signed by a physician. It does not have to be the original, but it has to be on yellow paper. And on many DNR forms, there's a little like pocket card that you can cut out and put in your wallet. That is deemed legal as well. Unfortunately, other things do not work. I think we should have a better system where you can make your thoughts known without having a yellow piece of paper, but none of this worked. There was a big case a couple years ago where a guy had "Do Not Resuscitate," that picture right there, tattooed on his chest, and it became this huge ethical issue. Because people say, well, he doesn't want to be resuscitated. And we say, well, maybe he got that tattoo when he's in a different mindset, and now 10 years later he actually wants to be. So I think you should probably get it crossed out if it's not true anymore. But things like that, even unfortunately DNR bracelets, aren't a legal binding thing. So if you see this on someone but don't have a paper, that's a great time to try and talk to the family. Do we have someone who makes decisions for them? Do you guys have that DNR? Because legally you can't go by this bracelet. In the hospital, I would in a heartbeat. I would not resuscitate this person if they're wearing that bracelet, or maybe I give it one good round and stop. But just know, in terms of legal binding documents, you have to have that yellow state of Florida piece of paper. Also, DNR can only be revoked by a physician, the patient, or the legal person who is signing that document. If a family member is there and tears it up in front of you and says, no, I want you to do everything, unless they are that legal decision maker for that patient, that DNR is still active. So we've seen this many, many times. You may have seen in the field of families really not being happy about a DNR form, and they want to revoke it right then and there. But legally, only the patient, the physician, or the actual legal signatory on that form can revoke the DNR at that time. Now, this can become a big issue in the field, and I wouldn't at all fault you for just loading that patient in a truck and bringing them to the hospital for us to figure out. It's a lot to figure out in a home when you have a very upset family in a critical situation. And I keep going back to you all being such an important role in the healthcare chain and bringing that information to us. A lot of these patients that get to us, we don't have any of this information. I would love to think that our computers are well connected to Baptist and Memorial and all these other systems, but they're not. And we may not have this information. So when you see that seriously ill patient and you get a whiff that, okay, maybe this person might be dying soon and maybe this person has end-of-life wishes, talk to the family real quick. Hey, who makes decisions? Do you have any established advance directives or DNR forms that we need to know about? And what is a phone number that they can call you at? Because again, these patients get dumped on us, and 8 hours later, we still have no family members coming in to help us out. So the amount of you guys don't truly understand how important that information is to what else happens. So this is going to be case 1.1. So the same patient that we had before, but now we're going to say this patient is actually enrolled in hospice. And so I think it's important to think about what actually is hospice. And so hospice is a specialized area of care when patients have entered kind of their end-of-life phase, usually in the last 6 months. And it's less focused on curing the disease and more focused on optimizing their quality of life. So if this patient has less than 6 months to live, how do we keep them comfortable? How do we keep them out of the hospital? Because they've said to us they don't want to die in the hospital. How do we keep them surrounded by family? That is hospice care. Just like with a DNR, hospice does not equal do nothing. This is the biggest misunderstanding we have. I try to enroll patients in hospice, and they say, oh, no, that means you're going to do nothing, just let me die. No, it doesn't. It means we've realized we can't cure you anymore, and we're now going to shift the focus of care to keeping you comfortable in meeting your wishes. That is hospice care. And so you might get called on patients who are currently enrolled in hospice. It's important that you have an understanding of what it is and how to kind of maneuver the system. Hospice is comfort care. Like I said, it's for those patients in the last 6 months of life. That's how you get enrolled in hospice, and it gets your nausea and pain, other symptoms under control, your dyspnea, and it makes sure you're in the setting you want to be in as you live out the end of your life. So step number 1 as a pre-hospital provider, if you get an active hospice patient, if you can, stop, pump the brakes, and get hospice team involved. Find the number for that hospice. There's only a couple hospice groups in our region here. Get the number for them if you have time and call them and say, I have a patient of yours. I need to know what the treatment plan is. Because the problem is that I had this patient just the other day where a new hospice nurse came in, didn't know the patient well. They got kind of worried. The husband got super worried of the patient's system and called 911. And that becomes a problem because the patient actually gets disenrolled from hospice when they go to the hospital. And also, it's not meeting the patient's goals. If a patient is enrolled in hospice, more likely they have said, I do not want to go to the hospital and receive care in the ICU or be admitted to the hospital. So we need to pump the brakes, talk to the hospice nurse, talk to the hospice program, and see what their plan is. Hospice organizations are fantastic and amazing. They will send someone up to the house and they'll say, oh no, hold on a second. We talked to the family about this. We don't want this. We're sending a nurse right now. I know it takes time. But now you can truly do the best for that patient. Think of that as your mom and your dad who's in end of life and they've made their wishes known. Try to take time to talk to that hospice organization. A lot of times those patients don't need to come to the emergency department. They've actually said they don't want to. It just takes a little bit of extra time. And these patients, most hospice patients are going to be a DNR as well. Most hospice organizations will not take a patient unless they have an established DNR. So if you have that hospice patient at home, ask, do you have their DNR form? Do you have their advance directives? And like I said, try to obtain an active treatment plan. The nurses with hospice, they always have 24/7 phone lines. They know what this patient wants. They know their regimen, so they can really help out and often have a nurse come to the house and continue to treat their symptoms. A lot of reasons patients in hospice come to the hospital is just out-of-control symptoms. Bad metastatic cancer, bone pain, whatever they're taking at home isn't cutting it. So instead of going to the hospital, the hospice team might actually be able to come bring higher doses of medication to the bedside. All right, so case number 2, 80-year-old female with severe dementia. She's bedbound. She's non-communicative. EMS is called for shortness of breath. She likely has an aspiration pneumonia. She has no documented advance directives or DNRs, and the family is on scene. So there are 1,000 reasons for us in pre-hospital care to go home at night and lose sleep and have ill effects mentally down the line for all the shit that we see day in and day out. And one of the reasons for this, and also in our emergency department, is I don't want this person who's demented and been in bed for 3 years to be put on a vent and die on a vent. This person probably doesn't want that. The family probably doesn't want that. So what we need to talk about real quick is just how to establish some goals of care. What goals of care are is what does this patient want? And that demented elderly patient who's in the end of life is not going to be able to tell you what they want. So the family is going to have to tell you what they want. It's just some simple questions we can ask to think of, is this really the best thing for the patient? Do they really need to go to the hospital? And you may not be able to make that decision, but at least when you get to the hospital, you can say, here's what I talked to the family about, and here's what they expressed that this patient may want. So goals of care have a couple different components. It has to do with prognosis, which generally the patients, the family may not really know. You can't be expected to know as well. But when we think about goals of care, we think about prognosis, the patient's value, and the provider experience and expertise. So as a provider, I've been a provider for a long time now. I can generally look at patients and say, yep, they're probably going to die in a couple months, or nope, they got a couple years to live. It just kind of comes with experience and expertise. And we put all this together and we come up with the patient goals of care. Now, in the hospital, in a palliative care setting, this is an hour-long conversation to come up with patients' goals of care. On the truck, it's probably about 2 minutes at most. But you can ask some very simple questions that by the family or the patient, if they can still communicate, that can then help us along and determine what's best for this patient. So two little quick blurbs that we can think of. Hey, I'm so-and-so. I'm worried that given how hard it is for your mother to breathe, we may have to place a tube in her airway to help her breathe. Has she ever discussed her wishes if something like this were to happen? That's a simple, quick statement. It's not, okay, she can't breathe, let's tube her, we're going to the hospital. If family's there, hey, has she ever talked about this? And son, daughter, husband might say, yeah, I mean, she's told me 10 times she never wants to be on a mechanical ventilation. She'd rather die at home than do that. Okay. Well, then let's do some other stuff to maybe keep her off the vent until we get to the hospital and have more time to think about this. So maybe think about CPAP, BiPAP, just even bagging the patient if it's a quick drive. I would much rather you roll in with that patient saying, we talked to the family about this. She does not want to be intubated, so we did everything we could to keep her stabilized till we got here. Fantastic. That's awesome. Instead of just, whatever, I'm going to tube this woman. And now she's living out the last couple of days of her life on a vent where her family has to come to the ICU to see her. It's a little conversation like that we can have. Also, another thing we say, since your mom is unable to speak with us, we were hoping you can tell us more about what she would say if we told her she was going to be placed on a breathing machine. So that's always a good way to frame it. Hey, your mom can't talk to us. You've known your mom forever. You are now speaking for her. What would she say in this instance? What would she say if we wanted to give her pain meds? What would she say if we wanted to put a tube down her throat and help her breathe? And framing it and putting it on the family, say, hey, you know this woman so much better than I do. I need your help in this right now. They may not be able to come with a great answer, but if they tell you, yeah, mom said over and over again she doesn't want to die in the hospital, cool. Okay, we're going to take that into account when we come up with our treatment plan. So one, it can help your treatment plan. It might help you pump the brakes in intubation if you can probably just get the patient to the hospital for further talks with the family. And two, it's that information that we need. You guys, I would say it 30 times this lecture, you guys are a huge source of good information. If you come to the bedside, this is what the family said. Mom does not want to be tubed. We got her here for you guys to talk some more. Awesome. Thanks so much. Here's advanced directives. Here's the hospice number. Blah, blah. All this stuff is so helpful to optimize this patient's experience and meet their goals of care. Saying all this, I will always put this out there. Stay within your protocols. All right? Do what your protocols say. If you think your protocols don't meet the needs of these types of patients, talk to your medical direction, get them improved. But always stay safe, stay within your protocols. All right, case number 3. We have a 50-year-old male out of hospital cardiac arrest, multiple rounds of ACLS, asystole, 20 minutes of total CPR. So you and your crew arrive and transfer the patient to ED bed. I roll in there, thinking I'm my hero. I ultrasound this patient. Within 10 seconds, I say, we're calling it. Time of death, so-and-so. Thanks, everybody, for a good job. I had this exact case. Has anyone seen this before, where you guys bust your asses for 20 minutes in the field? Clark, I know you never have. And then get to us, and we call it within 10 seconds. Anyone had that experience before? That feels like shit, doesn't it? Oh, sucks. And first off, I apologize for that, because I'm going to talk about why it's really important for you guys to be able to reframe this in your head and why we do what we do. But we had this with Station 10 a week and a half ago. I think it was a GSW trauma. They worked their butts off, man. They did everything right in this patient. Came in sweating. I could tell they had a hard ride. Got to us within 10 seconds. We ultrasounded, called it, and everyone walked away. And I could see one of the medics from Station 10 just like, what just happened? And I could see him walking out to the truck and just pissed. And rightfully so. No one had explained to them what's going on, why we do what we do. And they walk away thinking, I just wasted 20 minutes on this patient when nothing was done. I think it's very important that you reframe this in your mind as to why that happens. So first off, talking about survival in cardiac arrest in the out of hospital setting. Anyone know, you guys probably know, but the average survival walking out of the hospital if you have a cardiac arrest outside the hospital? Anyone have an idea percentage-wise? That's a good estimate. What's that? I'm going to say 10 to be generous. It's very community specific. I would say in Northeast Florida, it's probably about 10% max. You get some communities where it reaches 30 or 40% based on some other treatment modalities. And what do you think the most important thing that decides that outcome is? Even before that, recognition. What else? CPR. Unfortunately, the decision's almost made before you guys even get it. Bystander CPR is the number one thing. Our community has horrendous bystander CPR statistics. Many communities do. So you can think that by the time they get to us, how many chances they've had for survival, because you guys are the next best thing. So we think about survival at time, cardiac arrest. Once they're reaching 30 minutes of cardiac arrest for survival, if they come to us without a pulse, especially if they're not shockable, they're done. It's the unfortunate truth. We might get back a small percentage of those, but they are not walking out of the hospital. So when we start looking at the timeline, this is stuff we think about. I'm going to go back to my friend Lieutenant James Tucker, who died a year ago in his home. He had a witness cardiac arrest, bystander CPR by his wife, who is an emergency medicine physician. He lived 5 minutes from Mayo and had a badass emergency doc that I trained running the resuscitation in the ED, and that man didn't survive. And it's just goes to show that survival in out-of-hospital cardiac arrest is unfortunately low. It doesn't mean we don't work our asses off to save people. We just have to have that understanding, and we have to realize it's not a loss for us when we don't get these patients back. If you get them back, it's a win, but it's also we have to realize it's not a loss. That's nature we're playing against, and there's only so much we can do. Start talking about trauma, penetrating trauma. If you lose vital signs in the field and you're not within trauma center within minutes, like 5 to 10 minutes, you're not surviving. You're just not. So if you ever seen us do a thoracotomy where we cut the chest open in the trauma center and try to relieve any blood and open the heart and stuff, if you didn't have a pulse or vital signs within the last 10 minutes, we're generally not doing that because it doesn't help. It doesn't improve survivability at all. So generally we're not doing that, and that's only 10 minutes. And think about your ride times for most places in the city. 10 minutes, that's a long time. That's from like the time that the injury actually happened. So imagine it's very low survival. Blunt trauma, even less. Blunt trauma survival, if you guys get to a blunt trauma and they're in cardiac arrest, Generally speaking, 99.9% of the time, that person is not going to live. You still have to do your job and try your best, but they're probably not going to live. It's just the way blunt trauma works. Blunt trauma doesn't have a bleed that we can hold to pressure on stop. It's something devastating that happened inside the body. And again, if they get to us and they're still in cardiac arrest from a blunt trauma from MVC or something, we're probably not going to do anything because the survival is 0 to 1%. So this is all piece of the puzzle. Your job in cardiac arrest, no matter the cause, is to get to the patient, determine if it's safe to get on the scene, establish the patient in cardiac arrest, start early CPR, defibrillation if indicated, and get them, depending on the protocols, get them definitive care as fast as you can. Or run a really high quality resuscitation in the field. There's other things that go into that. We have more time to think about. By the time you get to us, I've already thought about their age. I've already thought about if they had bystander CPR. I've already thought about the rhythm that they had, what downtime they have, the trauma associated with it, what their entitled CO2 is. That's all information I have by the time they get to me. So I'm able to put those pieces of the puzzle together and make more of an informed decision than you have time to do in the field. I also have fancy equipment like an ultrasound. Ultrasound is everything in cardiac arrest. If I look at a heart after medical or trauma arrest, and it's been 10, 15 minutes, and that heart is not moving, that person is not living. That's the end of it. It's unfortunate, but when a completely standstill heart, you might get a couple of those folks back, but they're never going to walk out of the hospital. It's such a devastating injury. Unless there's something that we know we can fix that time, those persons just don't survive. So that's why we still push our resuscitations usually out to 20, 30 minutes, but usually that time has elapsed by the time you guys get to us. You've run a great resuscitation for 20 minutes. There's unfortunately nothing else for me to do that's going to improve their outcome. So looking at overall statistics, medical cardiac arrest greater than 20 minutes with no cardiac activity on arrival, around 0% survival. Penetrating trauma, greater than 15 minutes, no cardiac activity. Blunt trauma, greater than 10 minutes, no cardiac activity. All of these equal about 0% survival, depending on your community. So this is why by the time they get to us, we sometimes aren't doing anything. Our peers are not doing anything, but we've already spent the time that we've had to develop a plan to decide there's not much else we can do. So I want to get in your heads that it isn't that there's nothing to do with this patient. It's that the absolute best efforts that we had and chance of survival, you have done. You've done good CPR. You've done defibrillation as indicated. You've done all the things that gives this patient the best chance of survival. So me doing it for 10 or 15 minutes more isn't going to improve on that. So we just have to keep that in the back of our heads. Is that despite your efforts, this patient still isn't surviving. So in these instances, please come talk to us. I've seen this so many times over the years where pissed off crews, rightfully so, turn around and walk back to the rig and say, well, that was a waste of time. How can I expect you to then try to go do another resuscitation? We say, hey, no matter what I do, nothing's going to happen. So please come talk to us. Come ask, hey, why didn't you guys do anything? What did that ultrasound show? Do you mind showing it to me? I noticed we bust our asses and you guys just kind of stopped. We're just curious why that was. Should we not have done all this? Come talk to us. And you will sometimes talk to an asshole and then just stop talking to that asshole and come talk to me. Most people know how to get in touch with me, but find a physician who wants to talk you through it because I think that can truly change your mindset with these cases. Any questions on that? Because I think that's very important. Okay. So last one we're going to run through here. This is kind of the same case. We've got that same person. We have a 50-year-old out of hospital cardiac arrest. They've now been down for 30 minutes. They've had high-quality ACLS. They have no return of spontaneous circulation. And this agency has a termination of resuscitation protocol in place. And this agency is also 30 minutes from the closest hospital. So who all has utilized a termination of resuscitation protocol in the field? Meaning, I'm actively working this patient, and now I've decided to stop. I see a couple of hands. I'm not surprised it's only a couple of you. Who all has a termination of resuscitation protocol? All of you should raise your hands because you all do. It's not utilized much, and there's lots of reasons for this. You go to a gunshot wound in a community, and you have 10 people around your truck. When you pick this person up, I'd be very ballsy of you to say, you know what, they meet our termination resuscitation protocol. I'm not going to do anything. That would be a very ballsy move by you. So we don't blame you for scooping that patient and bringing him to trauma center. You have a prolonged downtime or nursing home patient, demented, been in the bed for 10 years, and you come home, the nurse doesn't know downtime. You're probably going to run that resuscitation unless they have obvious signs of death. Because, again, it's hard to ask you guys to do nothing. And it's a liability issue. There's lots of things that go into it. But do know, you do have a protocol. This is JFRD's, at least as of a couple of years ago, maybe been updated, but most of them are going to be pretty similar. This is the unquestionable death criteria, so unresponsive, apneic, pulseless, and then all the signs of obvious death that we've all learned in EMT and paramedic school, decapitation, rigor mortis, full thickness burns the entire body, that kind of stuff. That's your obvious death criteria. We then have a trauma death criteria. So these are patients, blunt chest trauma or multi-system trauma with apneic, pulseness, and if the cardiac rhythm is a systole or wide complex rhythm of 30 or less. I have seen this patient get rolled into the trauma center 1,000 times over the last 15 years. And we know there's nothing to do for us, and I've had people, physicians, get up in arms. Why the hell did they bring this patient to us? Again, I understand why you wouldn't call this in the field, but just know that this is why these, what we talked about before, this is why these actually exist, is because these patients are not going to survive no matter what we do. You then also have a medical asystole one. So it's a lot to read through, but when all the criteria exist, the patient's in a long-term care facility, arrest not witnessed, no shocks provided by JFRD, patient greater than 18, rhythm remains asystole after providing 3 rounds of ACLS, and advanced airway in place. If all of those are present in this patient, by your protocols for JFRD folks, you can call the termination and say we're not doing anything anymore. Probably talk to the chief, medical direction. So just know that does exist. Again, I know why this isn't utilized. This is usually utilized more in more rural agencies when you have a long transport time. A lot of our patients are within 5 to 10 minutes of us, so again, can't blame you for just loading the patient and getting to the hospital. But I want you to realize, again, I go back to what we talked about before, is what you all bring to the picture. Pre-hospital cardiac arrest, hospital cardiac arrest. There's not much different between these two things. We don't have many fancy things that we do in the emergency department. If you give high-quality CPR and defibrillate when needed, you've done 90% of the job. Your CPR is sometimes much better than CPR we get in the hospital, depending on doing the CPR. But look at these scenes. They're exactly the same scene. So I ask you this question: what saves lives in cardiac arrest? And we talked about this earlier. What saves lives? Good CPR, defibrillation when needed, plus or minus airway depending on the situation. But it all comes down to high-quality CPR, high-quality initial resuscitation within the first 5 minutes. But by the time they get to us, that time has elapsed. That can happen in the field. And if despite all of that, they still get to us and are still in cardiac arrest, there's a very high chance there's nothing else for us to do. And it doesn't have to do with your performance. It's the fact that you've done a good job and they still haven't had return of spontaneous circulation. So then that begs the question, the age-old debate of stay and play versus load and go. This continues to be a huge debate in the pre-hospital literature and the emergency department literature. Because from the pre-hospital side, we think of, okay, well, can we just utilize all of our resources, and do we need to use that truck to maybe take this person 30, 40 minutes? Is that worth it? On the hospital end, we say, do we need 5 more bodies that we can't do anything about when we already have 50 people in our department and 10 people in the hallways, and we can't do anything about this? So it's a debate on both sides. So this is from a very well-known podcast, but there's lots of debate on it. There's a lot of articles and podcasts about it. It comes up all the time. So this is there's an argument for stay and play and load and go. The argument for stay and play is looking at your CPR quality. So CPR quality decreases, and there's plenty of studies to show this. With every intervention that we do, our CPR quality decreases. So you get on scene, you start wailing away on the chest. You're doing good CPR. You're an engine crew. Rescue shows up and say, okay, let's go ahead and get him on our Zola. Okay, put him on. We stop CPR. Okay, let's get him on the stretcher. Okay, we stop CPR. Okay, cool. Let's get him in the truck. Okay, we stop CPR. Okay, I'm trying to intubate the person. Okay, we stop CPR. Okay, we're at the ED. Get him off. Every time I meet the trucks at every cardiac arrest I work, I meet them out at the ambulance bay. And I've seen a lot of people come in without CPR being done, because there's other stuff going on. And I understand that, but there's other people are disconnecting stuff, and I open the bay doors, and just no one's doing CPR. And we can't have that. Lucas devices help with that, but you can see every single thing we do, the quality of CPR decreases. So then that begs the question, what if we just stay and do CPR, and we don't get the patient in the truck, and we don't try to intubate, and we don't take them to the emergency department, and until we've done everything we absolutely can on the scene? Because if we're to do that, theoretically, we get high-quality CPR, whether that's a person or whether that's Lucas just going and sitting there and making sure that we're not turning Lucas off, we're not doing all this other stuff. We are just giving high-quality CPR to give that patient the best chance of survival. So that's the argument for a stay-and-play approach. There are reasons to load and go a patient. I'll talk about it in a second. But I bring up St. Johns County protocol. This is pretty recent. I'm not totally sure this is what they are functioning with right now. They have a lot of different steps in place with Eligard and some other things that do. But the whole idea of this protocol is minimum 30 minutes on scene and less ROSC. So when they're using this protocol for their patient, they'll work that patient for 30 minutes. If they don't get ROSC at that point, they can either determine to terminate resuscitation or go to the hospital. Because they know they're able to do CPR, they're able to apply a defibrillator if needed, and they're able to give high-quality CPR and intubate if needed. They might do a supraglottic or something, but all that can be done in the field to very high quality. And now the CPR quality hasn't dropped at all. They're not moving the patient around doing all this stuff. And so even if they decide to transport later, they've done everything they can possibly do. But they may even get to this point and say, you know what, this person doesn't need to be transported because despite all of this, they're still asystole. Let's talk to med direction and see if we can just terminate resuscitation. So that's why you'll see protocols like this that have a minimum of 20 minutes or minimum of 30 minutes before you're even allowed to move the patient and get him to the hospital, because you can really get high quality care there. I mean, think about the times you're having to get someone out of a bathroom or out of a home into the truck and how many interruptions in CPR there are. You just think it's an unfortunate truth. Now, there are reasons to load and go, definitely. I wanted you to be aware of some more kind of advanced reasons. We do have things like ECMO that we're trying to implement more. There's some patients that may need to be put on ECMO, and that's essentially a heart bypass, so we can maybe get them to a cath lab. So a STEMI patient who's having obvious STEMI and then goes into cardiac arrest, they need CPR, but they also need to go to a cath lab. So maybe that's the patient that some protocols will say, go ahead, get them to the hospital as fast as you can. Trauma patients, like we talked about, a bleeding trauma patient, cardiac arrest, yeah, we want you guys to get them there quickly. Again, we might terminate resuscitation when we get there, but at least if you're able to stop that bleed and get them to a place where they may go to the OR, that's the care that they need. And like I said, cath lab. STEMI patients will need to go to the cath lab. So there are protocols that kind of tease all these things out, but this would be reasons why even in a rural place they might say, okay, go ahead and load and go, because we need to get these patients to definitive care. All right, so where was I going with this? Oh, so let's say in this patient you have decided to terminate resuscitation. And again, it's probably not going to happen in most places in Jacksonville, but if you're a Baker County or more rural agency and you said, you know what, I want to go ahead and terminate resuscitation. I want to talk about a few quick things with this. And first off is family presence. You guys have probably had family around while you're resuscitating a patient, but this has been something that's getting more evidence for it in the emergency department is, does it help to have families there when we're resuscitating a patient or terminating resuscitation? Because the traditional way was whisk the family in the other room and don't let them see what's going on, because God forbid they see this, it might give them trauma or depression down the line. There's actually studies showing that if the family is able to watch the resuscitation and be a part of that decision to stop resuscitation, they actually do better down the line in terms of PTSD, depression, issues like that. They're able to deal with that death much better. It's very interesting science, but you'll see it more again in the pre-hospital phase if you work at an agency that is focused on a stay and play model. You might think about, do I want to have the family in there? And I do this in the emergency department. When we know we're going to stop resuscitation, I'll call the family in. I'll say, hey, I'm going to probably cease efforts soon. Would you like to be present with us when we do that? And a good amount of families say, yes, I'd like to. And as we go in, I introduce them to the team. And what it helps them see everything we're doing. If you come back and say, we did everything, your father died, I'm sorry. They don't know what we did. But when they go in there and when they see us sweating away doing compressions, they see we've intubated the patient, they see the vent, they see ultrasound, all this other stuff, they take back with them, wow, that team really did a lot. So if you're at an agency or you're considering terminating resuscitation, the family's in the other room, it's okay to go outside and say, they're meeting our protocol, we've done everything we can, would you like to come in and see what we're doing or be a part of the care that we're giving when we terminate resuscitation? And families might say no, and that's okay, but do know that actually looking at the evidence actually helps patients down the line. It's counterintuitive, but it does help. The next small thing that a lot of you may not have to do, but I think it's good to talk about, is how to break serious news. Has anyone in here had to tell a family that their family member died? Yeah, anyone else? Yeah. Again, not something we do that much in the field, especially around here, because a lot of patients get brought into us. But you might have to do it, and it's good to have thought about it before you try to do it. It's a really shitty thing to have to do. I've done it too many times, but it's good to at least have an idea of how am I going to tell this person that their family member died. And again, hopefully something you guys might not want to do, might not have to do a lot. But I want you to know there are things out there to think through, how should I do this? There's training out there. I like to use the grieving mnemonic. I'll just go through each one real quick. I more just want you to be aware that it exists. So gathering the family in a private area. In the home, that's not a big deal, but you may be out somewhere or be in a skilled nursing facility. There might be another family or person in that room right there. So trying to get the family into a private area to have a good conversation. Having other resources that you need. In the hospital, for me, that would be the chaplain. But if you're out in the field, police officer, just to have them there to help. Or many families do unfortunately become violent when they hear the family members died. So it's good to have security or police nearby if you think that might happen. Having a neighbor, if there's a neighbor that's really close to that family, just to have a comforting presence with them. Identify yourself to the patient, family, friends. Know who's in the room. So when I walk in the room, I say, hey, I'm Dr. Schmidt. I'm the emergency doctor taking care of your family member. Real quick, who do I have in the room right now? Just to, okay, your husband, okay, your sister, your friend. I might have someone, oh, you have nothing to do with this? Yeah, I need you to get out. There might be, because we have other family members lingering around. But I want to know who I'm talking to. Because if I have husband and a couple friends, I'm probably going to focus on husband more, just kind of given that emotional connection. And educate on the events so far. Simple, direct, plain talk. The way I do this in the emergency department, if I have someone come in, I'm going to say, I'm going to bring you up to speed real quick. I usually say, first of all, tell me what you know so far. And they'll say, I don't know, they just collapsed, and I called 911, and I was too scared to do CPR, so the ambulance showed up, and I think they were doing CPR, and then they just took them away. And that tells me what the patient knows, because now they've seen their patient dead and unconscious. That might be a little easier than, I don't know, my neighbor called and something's wrong. Okay, now this person has no idea what's going on. So I say, okay, Dr. Schmidt, I want you to know that your husband went into what we call cardiac arrest. So that means his heart actually stopped beating. And the engine crew, the rescue crew did everything they could, gave him every medication they could. They couldn't get the heart start beating again. They brought us into us. His heart still hadn't started beating. So we continued the resuscitation, did everything we could. We could not get the heart to beat on its own again. So I have really simple talk. I'm not talking about cardiopulmonary arrest and all this intubation advanced terms. I'm just saying the heart can't beat on its own despite everything we've done. The next one is to verify death by saying death. And this is the hardest part. We don't say they passed away. We don't say we lost them. They might have a family member say, well, where the hell did he go? You lost him. He's no longer with us. He's in a better place. You say death. You say your family member, I'm very sorry to tell you, your family member has died. You have to use those words. Evidence shows that families and friends may not understand what you're talking about unless you use the word death. Give space. Give space just means shut up and let them take in that information. Don't overwhelm them with other information. Just allow them space to take that information in. After that time has lapsed, inquire about any other current questions they have. Nuts and bolts is, here's what's going to happen now. So in the hospital, I might say, what's going to happen now is our chaplain and charge nurse are going to come talk to you, talk through the next steps. We'll talk about if we need an autopsy. They'll give you information about where to go from here. You in the field might say, we're terminating this resuscitation from here on out. The police are going to come in. They're going to talk to you, talk about the next steps of where to go from here. Because families have to know, okay, what now? And then give contact information or be available later. It's something I do in the hospital. You don't blame me if you don't want to, but hey, I'm Medic Clark. If any questions come up, feel free to get in touch with JFRD. Here's my name, and if you have any questions, I'll do my best to answer them. It just gives a nice little full circle. I've had plenty of families contact me, and it's never pissed off. It's never, oh my God, why didn't you save my husband? It's contact me and saying, thank you so much for what you did. I've had 10-year-old daughters call me 11 o'clock at night because I gave the family my phone number just to say, I need to talk to you to know, did my dad suffer? I need to talk to you to know, did I do everything right by calling 911? You'd be surprised by how many families want to talk to you to say thank you or just to answer simple questions. It's never, why the hell didn't you do more for my family member? So again, this is how I would approach in the hospital whilst in the field. Hi, I'm Andrew. I'm the paramedic taking care of your husband. Please tell me what you know so far. Hear what they know so far real quick. As you saw when we arrived, we started CPR on your husband. This is because heart was not beating on its own. Over the past 20 minutes, we have continued CPR. We put a tube in his throat to begin to breathe for him. We've given him every medication we can give and to try to get his heart started again. Despite all of our efforts, we could not get his heart to start again. I'm very sorry to tell you that he has died. That is the script I use in almost every patient in the hospital, because if by having the script in my head, I'm not having to come up with it on my own. I will sometimes get emotional, not know what to say, so I need to have something that I can spit out real quick. You then pause, you shut up, and you let the family take in the information. They'll be crying, they'll be screaming, they'll be punching walls. You have to, even going back to defensive maneuvers, when you give this information, take the lay of the room, take the temperature of the room. Many times I'm next to an open door when I get this information, because I can tell that guy in the corner looks like he's going to come at me. And I've had people rush me and try to attack me just out of emotion. They usually apologize later, but just know people, emotions flare. So also just knowing to get out when you need to. At that point, I say, again, I'm so sorry I have to have this conversation with you tonight. I know there are a million thoughts running through your head, but I do want to ask if you have any immediate questions I can help with right now. What's going to happen now is the officer is going to stay with you while I go back and speak with my team. If you would like to come back into the room and see your husband, you're more than welcome to. I'll make sure everything is ready for that. The officer will explain what steps will happen next. And then optional, here's my name. If you have any questions, you're welcome to contact the department. Big thing is be human. If in the end you forget what the hell to do, be a human. Be kind, be nice, be empathetic. Do the best you can just to be a human. So that's mostly all we have. Big takeaways from this is have some idea of what advanced directives are, like DNR forms. Know what's legal and what's not legal. If you can establish if the patient has any known directives and establish who makes medical decisions for them, that is, I'll say it again, you cannot understand how helpful that is for us in the hospital. Have some idea what hospice is. And if you identify a hospice patient and you have time, contact the hospice, because there's a very good chance that patient is not supposed to go to the hospital. It can actually make things very tough for them if they go to the hospital. Bring as much information as you can to us. It's a vital link in the chain. Remember that we have fancy stuff in the hospital, and by the time you got to the hospital, you've done most of the work, and I have a lot more time to think about the case. So if I'm calling it real fast, it's probably because all the best chance for survival has already been done. Please come speak to us. Never be afraid to come speak to us. And if you try to speak to someone and they're an asshole, find someone else. And when in doubt, get my contact information. I'll speak to you. And just remember how much it matters what you guys do in the field. It really, really matters. And one more time, follow your protocols. Despite everything I ever say, please follow your protocols. But if in any lecture you ever see something that you think you aren't doing right in your agency, take it to medical direction and say, hey, I saw this lecture, I read this paper, maybe we can do this a little bit better. That's the only way that protocols get improved, is when the people who are actually practicing them come back to medical direction. And finally, I'll bring up James one more time. The reason I bring him up in this one is to talk one more time about advanced directives. I encourage all of you who have a family at home, who have a close friend, someone who cares about you, to go home in the next week and tell them what your wishes are. James died at 42. Fit, young, awesome person. Died suddenly at home. And he and his wife hadn't had that much of a conversation. It didn't matter so much in his part because it didn't get ROSC on him. But if he had ended up intubated in the ICU, his wife wouldn't really know what to do. If you're 30 years old, I've seen plenty of 30-year-olds die for trauma, for cardiac reasons. Have this conversation at home. Talk to your wife, your brother, sister, whatever. Say, hey, you know what? If something bad happens to me, I want you to know what I want. That might be do everything. I'm young, I'm healthy, do everything. It might be, I don't want to be on a ventilator. It doesn't even have to necessarily be written down. It's better if it is, but just talk to someone so they know. The worst thing is a patient who's 90 years old and family gets there and they say, well, you know what? We never had that conversation. Every time we brought it up, we got scared. But I promise you, it can really help and encourage it in your family as well. Encourage it with your parents. Encourage it with your loved ones. Hey, sit down real quick. Let's talk 10 minutes. If something bad were to happen, I want to make a decision for you. Tell me what you want. And it can really change a lot for a patient. And that is all I have. Any questions at all? Pretty straightforward stuff. Yeah? So the question was talking about power of attorney and legality issues, which I'll try my best to answer. Does that person have to be present, and what paperwork do they need? So ideally, you have the paperwork, because people may say, yeah, I'm Aunt so-and-so. I was designated power of attorney. I actually had this case recently where a son was there, and he said, yeah, well, Mom, right before she started getting demented, she made a random cousin in Kentucky power of attorney, and we think he's just been stealing her money the whole time. and he doesn't really care about her. So you start getting into some fishy waters. But if you can at least get the name and say, okay, do you have a legal document that tells me that? Because sometimes you just have to go on, this person says their power of attorney, but we don't know. So ideally a name and a document that says so, that's great. The person doesn't have to be there. But for it to truly be legal, if the person is other than who would otherwise make a decision, like a spouse or son or daughter, if it's someone else, that legal document is going to need to be present. If you come in and say, yeah, the aunt was on scene, she says she's power of attorney, and she says do nothing, I might take that in consideration. If it's a 90-year-old person who's been demented in bed for 5 years, I'm probably going to do nothing. But if it's someone else, I'm like, you know what, they might benefit from resuscitation. I don't have the paperwork. I may actually do something. And I would legally be covered because I don't have that paperwork in front of me. So really just as much information as you can get. If you have a document, fantastic. If you have a name and a phone number, awesome. The person does not have to be there, but that just helps immensely. Anything else? Yeah. So legally, that would be non-binding, which is not a Florida DNR. So legally, it would not matter. It's all piece of the puzzle. Again, you bring that patient in. Yeah, they moved here 2 weeks ago. Here's their legal New Jersey form. I'm not running a big resuscitation on this person. I want to meet their goals and wishes. If family comes in and says, no, since they've moved to Florida, they totally changed their outlook on life and they want to live forever, okay, I'll probably take that. The sunshine really cured them. I'll take that into effect as well. But just know legally, they hand that to you, say, okay, what that is a non-legal description of their goals of care. Awesome. This person has expressed recently that they do not want to be resuscitated. It's not legally binding, but in my head, that's that huge piece of the puzzle when I'm determining what do I do next in my resuscitation. So be very, not legal, but very helpful. Yeah. So copy of a DNR in Florida, as long as it's on a bright yellow piece of paper, it's legal. It does not have to be the original, but it's supposed to be on a yellow piece of paper. Again, you bring it on a white piece of paper, I'm going to use it very strongly in my decision to resuscitate someone. But legally, I'm probably going to do more because legally, if any of us were to be taking court of law, why didn't you resuscitate this patient? I can't say, oh, they had a DNR on a white paper. They say, well, that's not a legal document. So it can be a copy, but it has to be on on the yellow form to be a true Florida DNR. Anything else? All right. Thank you, folks.